just want to make sure that Teddy's not in any pain.
Oh, he's heavily sedated. He can't feel a thing.
Right. It's just that when I look at him, I just feel so helpless.
Look, his CT scans came back negative for internal injuries. He's on IV therapy to replace any lost fluids. I assure you, we are doing everything we can to give him the best treatment possible.
So what Whitaker is doing here is absolutely amazing. He's an awesome fourth-year medical student, and this is what we look for in a potential future resident.
Thank you.
Yeah, Teddy's ring. I had to cut it off because of the swelling. Hopefully you can find a good jeweler to fix it. I don't know how it works.
Do you have a best friend, Doctor?
Oh, it's another year to go till you can call me doctor.
When picking a future EM resident, there is so much more that goes into this than just simply book smart, good grades, good exam score. You know, are they a team player? Are they teachable? Are they willing to learn? Do they have a passion for emergency medicine? There is so much more that goes into kind of picking an applicant, interviewing an applicant, so much more. The connection he's making here, the reassurance he's making here, how he's interacting with the wife of this patient speaks volumes on the kind of medical student he is, and I definitely look forward to him, you know, in season 2, and kind of, I'm hoping he comes back as an intern this time, you know, as a first-year resident. That's what I'm hoping for. So awesome job, Whitaker.
You can just call me Whitaker, though.
Do you have a best friend, Whitaker?
I have 3 older brothers. Guess they're kind of my best friends. They kind of tortured me growing up, so maybe not. Yeah.
Teddy's been my best friend since we were 15.
High school sweethearts?
We were just a couple of nerdy Aggies who, we met in 4-H and we fell in love. I'm sorry.
No, it's fine. I'm a 3rd-generation Nebraska farm kid myself.
Get out. Well, if you're ever homesick, you should come by our farm sometime.
It's very kind.
I need some help in here.
What's going on?
Respiratory distress. SATs are dropping 87%.
Lung injury from the fire?
It's not just the low SATs. Events showing high peak pressure, low tidal volume.
So we hear high peak pressure and low tidal volume. Now, there's going to be some concepts in this critique that can get rather detailed, but I'm going to do my best to stay pretty broad. There's going to be a few things where I am going to get very specific, so I apologize in advance. We are going to take a deep dive on a few things, but I briefly wanted to talk about a couple things here. Peak pressure is basically the summation of pressure generated by the ventilator to overcome airway resistance and alveolar resistance to attain peak inspiratory flow and deliver that desired tidal volume. Put simply, it's the amount of airway pressure delivered by the ventilator to initially overcome the resistance of the endotracheal tube, the airway, and the alveoli. So after sustaining a full thickness burn, the skin basically shrinks. It becomes stiff, it becomes leathery. The result is called an eschar. So subsequently, a local inflammatory response occurs and edema forms wherever that burn is at. This increases pressure and has a number of potentially severe effects depending on the anatomical location of that burn. So if you have a burn, for example, it's on the limb, so it's on one of the extremities, and the pressure on that tissue exceeds that of the venous and lymphatic system, this is going to cause an increase in edema. So if that pressure on the tissue exceeds the arterial pressure, there's going to be loss of circulation. So deep burns to the neck, for example, can obstruct the airway. For the trunk, an eschar on the chest can severely limit the movement required for breathing, right? Inspiratory, expiratory, in and out. In these ventilated patients, burns can increase the ventilation pressures. You can also see abdominal compartment syndrome as well, but I'm not going to talk talk about that in this case. You could probably worry about that in this case, just seeing the abdomen and that potential burn. So there's a lot more that kind of goes into this, but I briefly want to talk about those high peak pressures, kind of what that means, what that means when you have a full thickness burn, what it's doing to the tissues, that's squeezing, and you're going to end up having those high peak pressures and low tidal volume, and that has to do with that edema, with that swelling.
Restrictive pattern?
Most likely. I'll grab Robbie and Langdon.
I will grab Dr. Robbie and Langdon. Perfect. I was waiting for this. It is great the medical student showed up. I love it. But getting the senior resident and attending is what is realistic here. I was waiting for the medical student to start giving off all these orders. I need this and this and this and this, when that's not going to happen. Now, it's one thing if, the patient's got no pulse, sure, go in there and, start doing CPR, do all this stuff. They do all that. Put simply, I'm talking about actual, placing orders, giving orders, doing things like that. In reality, again, it's the attending that's running the room. It's the ER nurse is going to get that attending. They're going to get one of us. So many times in TV medical dramas that I mentioned, the med student is doing all these things that they cannot do in real life. I've already mentioned Chicago Med. Giving medications when a resident or attending has not signed off on that is just 100% not realistic. So again, I just want to put that caveat in there. I'm glad that they finally said, go get Dr. Robbie and get Dr. Langdon. That's perfect. That's appropriate. That's what's going to happen.
Wait, what's that? What's going on?
Ventilator is having trouble pumping air into Teddy's lungs. Burnt skin loses elasticity. Now his chest wall's too tight.
Well, what can you do?
We're gonna have to cut the burnt skin, release pressure on the chest wall, help Teddy breathe.
Boom, perfect, great explanation of this. So the thickness of the dermis and the epidermis varies depending on location, age, and gender. Deep to the skin is the subcutaneous fat and then a fascial membrane layer before the deeper structures like muscle. So heat and other injury mechanisms can denature proteins. That leads to the loss of the plasma membrane integrity and cell necrosis. So superficial burns only affect the epidermis, right? They're clinically painful, their erythematous are red, they blanch on pressure. Partial thickness burns involve both the epidermis and dermis. Clinically, they can appear pink or cherry red, they blister, again, they're sensate to the touch. You can still feel this. They blanch on pressure and they're also painful. Full thickness burns, on the other hand, affect the epidermis, the dermis, and subcutaneous tissues, forming an eschar. Clinically, these burns appear dry and leathery, but they're not painful, they're not sensate or blanching. They actually feel firm and waxy on palpation. In limbs, for example, if you get this circumferential, so all the way around, full thickness burn, it's going to act as a tourniquet, right? Getting back to that edema and that swelling, just squeezing everything. And it's going to restrict that circulation distally. That's going to result in tissue ischemia, tissue necrosis, right? You can imagine if you are squeezing something, anything on the inside of that, if it's squeezed enough, if there's enough edema, is going to cause that tissue ischemia and necrosis. So on the chest and the abdominal wall, for example, due to the inflexible nature of that eschar, normal respiratory motion of the chest and the abdominal wall movements are restricted, thus limiting normal respiratory function. And so the big thing with this is that if you have that squeezing, you can imagine it's going to be harder to take that deep breath. It's going to be harder to even exhale as well. So really to do both of those things, to do any kind of movement depending on that constriction itself.
So after you cut his eye, see you again?
This will give us our best shot at preserving his vision, yes. Dr. McKay, are you ready to do the honors?
Who, me?
We are a teaching hospital. Are you still here to learn?
Yes.
Okay. You can release that hemostat now.
So I wanted to stop at this point before they get too far into the procedure itself, because what he did at the beginning was perfect and with such a small detail that I doubt, seriously, I doubt any other TV medical drama is going to do this. You will notice here he's actually holding this hemostat, right? It's straight up in the air, he's holding it, and that's clamped. And he appears to be holding it in place. Again, such a small detail here. So what we're going to do now is we're going to go through the procedure of a lateral canthotomy with cantholysis. I'm not going to say this is one of my favorite procedures. I've done this a handful of times as an attending and a handful of times as a resident. It can be scary at first, but when you do it, this is relatively pretty simple. It's just kind of the bleeding, and we'll talk about that. But I want to talk about this now before it happens here, before we watch it on the TV show. So really step one is you're going to clean and irrigate that lateral canthus area, literally the area that you're going to be doing this procedure at. You're going to prepare that area with antiseptic. It doesn't matter if you're using betadine, chlorhexidine, both. Like, it doesn't matter, just it's going to get cleaned off. Next, you're going to begin by anesthetizing the site of the incision. So typically, I'm going to use a 25 gauge needle. I'm going to inject approximately about 2 cc's of either 1% or 2% lidocaine. But the key thing here is epinephrine, because an epinephrine itself is going to really constrict, it's going to reduce that bleeding. We want to reduce as much bleeding as possible because we'll talk about it here in a little bit, but when you're trying to feel for that tendon, sometimes you can't see it because of all the blood. So it literally find a guitar, see what that feels like on the strings. That's what you're feeling. That's what you're looking for in this case. What we're going to do here is we're going to inject that along that lateral canthus, pointing away from the globe, right? You don't want to go towards the eye. And make sure it's obviously in the affected eye, not injecting on the other side. I just wanted to put that out there. We're applying the local anesthetic, yes, but the epinephrine is going to help with some of the bleeding. So again, the majority of these procedures, when it comes to finding and cutting the tendon, are done by feel alone. But we need to make sure we're reducing that bleeding as much as we can to help us out. So step 3, next we're actually going to use a needle driver or hemostat. This is what he was doing in this case. Approximate the path of the incision. So whatever incision you're going to make, that's where that hemostat's going to be at. So from the lateral canthus to the rim of the orbit, and you're going to lock that hemostat in place. Literally, you're going to hear it click. All right. Now you can do this anywhere between 20 seconds to a minute. I like about a minute 15. Everybody's a little bit different with this, but you're crushing the tissue as well. And so that's actually helping with hemostasis. So now we have the epinephrine that was in the lidocaine, right? We just used the hemostat. So overall, this step serves really 2 functions. It's going to help with the landmark, but it's also going to make the skin thinner for an easier incision. Like if you compress this, if this is clamped down, it's going to make it so much easier. And again, it's going to reduce that bleeding. And then this is also the same thing that Dr. Robbie was doing here. So seriously, what other TV medical drama gets that level of detail like this? I'll wait. 0, none. This is only the PITT that's doing this. So again, I may be critiquing on a very detailed level, unlike any other YouTube channel out there. We're going so far in depth and I am looking at every single thing. But, again, there's plenty of critique along the way, but, this is the most accurate, while not 100% realistic, the most accurate medical drama ever on television. All right, so number 4, next you're gonna raise the skin while using either a surgical blade or a pair of scissors to make a 1 to 2 centimeter incision at that same location you held pressure. Remember, we just dealt with that. You're using that hemostat and it's kind of creating almost that line for you as well. It's gonna make it easier. So I prefer scissors here. To perform the canthotomy, you're gonna cut from that lateral canthus to the rim of that orbit using iris scissors. So following the path of that crushed tissue made on that previous step, the max length of the cut should be not more than 2 centimeters. And the reason for that is that temporal branch of the facial nerve passes through this area. Obviously, you don't want to cut that. So, a centimeter and a half is probably the normal with that, but really not more than that. Next, you're going to perform blunt dissection until all the tissue is out of the way and the lateral canthal tendon is identified. Once the inferior crus of that lateral canthal, you have a superior crus and you have inferior crus. Once the inferior crus of the lateral canthal tendon is identified, you're going to redirect the surgical blade or scissors inferiorly and you're going to strum along that tendon. Once the tendon is strummed, you're going to cut the fibers of that tendon until complete laxity, basically of the lower eyelid, is achieved. That's what you want. You're then going to recheck the intraocular pressure. If the pressure is still elevated, this procedure can then be repeated and then you cut the superior crus of that lateral canthal tendon. And you may wonder, you just watched it and you're like, wait a minute, she cut both. She did. She actually cut the inferior and then she cut the superior. They didn't even recheck it. They immediately cut both. In reality, we're cutting the inferior. We're checking the pressure. If it's still high, we're then going to cut the superior. I don't know why they did both in this case. Maybe because the pressure was already, I think it was 50, 58 if I recall. So it was already high. They're like, let's just cut both. But in general, we're going to cut the inferior. It's still high. We're going to cut the superior.
Iris scissors.
The length of the crushed area is going to be your guide for the length of your cut. Good.
Do the forceps. Feeling for the inferior. Superior Cruise. How can you see with all that blood?
You can. It's all tactile. Feels like two guitar strings.
Medicine bomb. Inferior
Yeah.
and superior.
All right, so let's go through some tips and tricks. So identifying the inferior cruce of the lateral canthal tendon can sometimes be tricky. So you're going to use scissors and you're going to strum that area to feel for that inferior cruce. If you feel tension literally like a string, the tendon is still intact and should be cut. So during the canthal lysis, you're going to cut inferior posteriorly toward the lateral rim to prevent injury to nearby structures superiorly, such as the levator muscle, lacrimal artery, lacrimal gland, right? These are structures that we want to avoid with this. Now, this is key here. In some situations, that superior cruce may also be cut to further relieve that intraorbital pressure. And then to do so, you're going to lift and expose that underside of the lateral upper eyelid and make the incision supero-posteriorly. So again, in this case, they just went ahead and cut both. I just want to put that plug in there of what we normally do.
Nice. Good.
Oh man, so I had such high hope for this procedure, and there was one small detail here that just made this not realistic. So let's talk about this a little bit. You're gonna notice after she cut both tendons, the swelling immediately went down, the bulge immediately resolved, and that is 100% not realistic. Nearly every time this is done, you cannot see the eye just go down. That is why you check pressures. If anything, right after you do this procedure, the eye actually bulges out more. And you're like, wait a minute, why would that? Let's think about that for a minute. Anatomically, all right, you have the retrobulbar hemorrhage or hematoma behind the eye, okay? That's pushing the eye forward, all right? Now what you have on the front are the eyelids, and they're holding it back. Literally, cutting that canthal tendon, like literally the canthal tendon is what's holding the eye from going all the way, from like popping out, right? So the end result is you have the eye in the middle and you have this increased pressure that's building up. The eye is literally being squeezed between the hematoma and the eyelid itself. So when you cut that canthal tendon, like when you cut that, you can imagine you're gonna initially get that bulge of the eye. It's actually gonna come out a little bit more. The eye actually relaxes forward. It does not just immediately deflate like you see here. This is so fake. Overall, the prosthetic looks awesome, but when it deflates, it looks like they had a balloon or something behind it. That looks so fake. In real life, if you have a retrobulbar hemorrhage and you do that lateral canthotomy, the eye is actually going to relax forward because that hematoma behind it now is pushing the eye forward, and there's nothing to prevent it. Now, eventually, as that blood resolves, as the bleeding improves, the eye is then going to relax back. Obviously, they need surgery and everything else, but overall, though, I would challenge any TV medical drama to top this scene. Again, I'm critiquing very specifically. We're getting into what the eye is actually doing after the procedure, especially if both tendons are cut. You can imagine if you just cut the one that eye popping out a little bit more after the procedure is probably going to be a little bit different than if you cut both, for example. But either way, I would challenge any TV medical drama to touch on the accuracy that they have here. I just don't see it happening. Overall, I'd probably give this particular case an 8 to 9 out of 10. Just a few key things that just made it not realistic. But overall, in terms of comparing this to any other TV medical drama, it doesn't compare. This is the best.
Well, that's a lot of blood.
Okay, let's get a repeat pressure.
It's getting a lot brighter.
Pressure of 18? Perfect. TG can take him as soon as we dress the wound.
Let's page ophthalmology and tell him to prep for surgery.
Doc, thank you. Thank
My
you.
pleasure, my pleasure. Good luck to you, Everett.
So she rechecks the pressures down to 18, solid, no complaints there. Dr. Robbie states to page ophthalmology and tell them to prep for surgery. This is 100% not realistic. You do not, and I repeat, you do not tell a specialist that has not seen the patient to prep for surgery. In real life, since we know they have ophthalmology at this hospital, they would have actually already been paged. If you're an ER doc and you page ophthalmology telling, hey, I have a retrobulbar hematoma developing an orbital compartment syndrome, and you do that, you're at your residency program and you do that, and you tell them what you have, they're going to immediately come down and see that patient, all right? In this case, it sounds like they really waited till the procedure was done to page ophthalmology, and that's just not realistic. Also, you never tell a specialist to prep for surgery. That is his job. You consult them, you tell them what you have, and let them evaluate the patient. We have seen this happen a couple times now in the PITT of calling the surgeon and telling them, prep for surgery, prep for the OR, right? It's dramatic, it sounds great. Call the OR, prep for surgery, we're on our way, right? It's just not realistic. If you're a resident and you have a ruptured appendicitis, for example, you call the general surgeon, tell them what you have. I have a 17-year-old with an acute abdomen, CT shows a ruptured appendicitis, white count's 18, patient's NPO 8 hours ago, they got Rocephin and Flagyl, which is pretty normal in the ER for this. They're gonna come down and see that patient, and then they're going to prep the OR, they're going to board that patient, right? They're going to see that patient first. If you just call down there and tell them what you have and say, Dr. So-and-so, I need you to prep the OR, this appy's coming to you, right? They're going to just look at you and be like, why are you telling me to prep my own OR? Are you the surgeon? Let the specialist decide what to do. Even though they're going to go to the OR, you don't tell the specialist that. It sounds great though, again, on a TV medical drama, prep the OR. It's just not realistic. Again, this is such a small detail. I just wanted to put it out there of what's realistic and what's not. So that simple statement, no ER doctor does that. No ER resident that's smart is going to do that. As an intern, I did this one time and I'll never do it again in my life. So you just don't do that. That's just not appropriate. That's just not what's done. Otherwise, the OR, the surgeon's just going to have a talk with you. I'll say that lightly and be like, I'll see the patient and decide if they need the OR. So don't make that mistake I did as an intern. But again, I just wanted to put that plug in there.
Hey, thanks for letting me do that.
You sound surprised.
Yeah, I figured after the whole Teresa thing, you might bench me.
Am I still pissed that you went behind my back? Absolutely. And if you ever do it again, you can bet your ass that I will bench you. But this is a teaching hospital, and teachers can still learn stuff. I saw a sad, confused boy, and that's all I thought about. I did not think enough about those girls.
Any word on Dana?
She should be coming back from CT soon.
Burn victim's tanking. We need you.
Oh my God, I can't wait for this shift to be over.
I can't wait for this shift to be over. I cannot honestly say how many times I have said that exact same thing. I have the night shift tonight. I'm gonna take a nap here in a few hours, and I already know I'm gonna say this at least once on my shift tonight. I can't wait for this shift to be over. Again, I love what I do, but it's pretty normal to say that when you're having a really busy shift, you're getting traumas and all these things come in, and you just can't wait for this shift to be over. That is pretty normal.
Hey, bud, you doing okay?
Yeah, Mateo hooks me up.
Yeah, I can see that.
How's Dad?
He's gonna need surgery, but he's gonna be okay. I was thinking, since your dad's gonna be laid up for a while, maybe you'd want to stay with me until he gets better.
For real?
Real. What do you think? That is yes.
All right, so we're almost at that point I told you to keep in mind when it comes to treatment of this ankle fracture. Remember, they tried to portray it as this deformed trimalleolar ankle fracture, which it wasn't deformed at all. It was basically a trimalleolar fracture. It didn't even look displaced on imaging. You can actually see the fracture lines through that. It looked pretty lined up. When you looked at it externally, there was nothing deformed. So for this next part, it really comes down to either, are we gonna manage this inpatient, so we're gonna admit them, or is this gonna be outpatient management? So let's talk about it. In an article entitled Inpatient or Outpatient, Does Initial Disposition Affect Outcomes in Trimalleolar Ankle Fractures? Johnson et al. Out of the Department of Orthopedics at Anne Arundel Medical Center stated, the repair of trimalleolar fractures can be challenging for surgeons, and it may be managed as either an inpatient or an outpatient. However, it is often unclear whether these patients should be admitted immediately or sent home from the emergency department. All right, so let's look at another published study. This one is entitled Current Management of Trimalleolar Ankle Fractures. Authors from the Department of Trauma Surgery in Munich, Germany, and the Department of Traumatology and Reconstructive Surgery in Berlin did an interesting retrospective chart review of 223 patients undergoing open reduction internal fixation of a trimalleolar ankle fracture performed from January of 2015 all the way up until August of 2022. Patients were classified by whether the fixation was performed as an inpatient or as an outpatient. They literally looked at both. The outcomes of the interest, what they're looking for, included the time from injury to surgery, any complications, the amount of ED return, so bounce backs basically into the ER, they were discharged and came back, and readmissions within 90 days. All these parameters were looked at. There was no difference in complications, 90-day ED returns, readmission, or reoperation between the groups. I will say overall, a multitude of studies exist. Whether it's in the United States, it's in another country, plenty of studies exist about the controversy about the optimal timing for surgery of a closed trimalleolar ankle fracture. Again, I'm saying closed, right? I'm not talking about open fractures here. This is different. This is a closed trimalleolar ankle fracture, very specific. And it's going to range from, hours to several days. There was another study. It was a retrospective cohort study in Norway involving 1,011 patients that showed no difference regarding postoperative length of stay, complications, and functional outcomes in patients with a closed ankle fracture treated with open reduction internal fixation, or ORF, during the first 8 hours, 8 hours to 6 days, and greater than 6 days. All right. Multitude of other studies are also in line with these findings. So how do we go about this in real life? You may be saying, Dr. Taylor, you just mentioned that inpatient versus outpatient doesn't really change anything in terms of a closed trimalleolar ankle fracture. So what exactly are we critiquing if it doesn't really matter either way? And it's what we typically do in the ER is where I'm going with this. But first, let's say this is a dislocated trimalleolar ankle fracture. We're going to immediately reduce this in the ER. If we reduce it and it's unsatisfactory, meaning you just can't get it to line up, it's just horribly unstable, right? The joint is so unstable. We're going to admit that patient, they're going to get surgery probably the next day. Obviously, a lot of other factors go into it, medical history and cardiac clearance, and are they on anticoagulation? Obviously, there's a lot of stuff that goes into that. But some other indications for inpatient, all right, includes severe soft tissue injury, compartment syndrome, and open fracture with or without vascular or nerve injury. These are patients that we admit inpatient. The patient on the PITT had none of these, right? There was no compartment syndrome. There was no severe soft tissue injury. It was not open. There was no vascular issue. There was no nerve issue, right? None of these things happened. They tried to say at one point an unstable mortise, right? In real life, we would have splinted this patient, discussed the case with ortho. I can 100% guarantee you, if you would have discussed this case with ortho, they're going to ask about all these different things. They may even say, can you get a CT? Why? It's going to help them as an outpatient when they do their surgery. But in particular, they're going to say, splint this patient, discharge them home, have them follow up, and we're going to schedule surgery. So if you watch my part, my part 1, and now this in part 2, you can see why this case overall is just so unrealistic. And this was a basic case. This was a simple case. Come on, I'll do better. Make this an open trimalleolar ankle fracture. Make it a dislocation. That patient would actually need propofol for reduction. They would then need a splint. We would admit them for surgery. Instead, what did we get? We got a closed trimalleolar ankle fracture with no deformity. They got 75 milligrams of propofol for a splint. Are you kidding me? I almost said something there. I resisted. It irritated me. And they were admitted for surgery. Yeah, right. That is not going to happen. 100% not realistic. This case should have been so much better. I could have made this so much better. It's actually disappointing. Come on, guys.
This procedure is called an escharotomy. We need to cut the skin so that the chest wall can expand.
That sounds painful.
Whitaker?
He's still heavily sedated. He won't feel a thing. This is going to help Teddy breathe.
SAT's 83, peak pressure's 40, tidal volume's only 300.
I want you to watch Dr. Langdon as he makes this vertical incision. Then you're going to do the exact same thing on your side and follow his instructions.
I'm sorry, I don't think I can
Jordan, would you?
So who does not love a good escharotomy? So for this, we're actually going to turn to Zollinger's Atlas of Surgical Operations, chapter 146, entitled Escharotomy. So in quotes, when the skin suffers a full thickness burn, that's that eschar that we talked about, it loses elasticity. At the same time, there's a shifting of fluid in the underlying subcutaneous tissues into the adjacent interstitial space. With this fluid shift comes an increase in tissue pressure. If you remember earlier, we kind of talked about that squeezing of that pressure. That inelasticity of the overlying burned skin, right, because it's firm, it's leathery, when it is circumferential, on an extremity, it can cause these tissue pressures to exceed the pulse pressure. Thereby, it's going to compromise blood flow to the extremity. On the anterior trunk, on the other hand, a full thickness burn can compromise respiratory mechanics, which is seen clinically as the inability of the patient to ventilate, followed by the inability to oxygenate. So to relieve these pressures and restore perfusion and or correct the respiratory mechanics, that's why we perform these escharotomies. That's why we do this. All right, so next up, we're gonna look at the University of Cincinnati indications for the procedure itself. I'm gonna put these on the screen for you. I'm gonna actually put letters next to each of these because the protocol I found online actually did this as well, so I'm gonna put that on the screen for you. So chest wall thickness burns hindering respiratory mechanics as evidenced by at least one clinical indicator, A or B, and at least one objective measure, C through G. So I'm going to read through all these for you. Patient hard to ventilate with bag valve mask ventilation, so BVM. Lack of chest rise with BVM. Hypoxia refractory to endotracheal intubation and not felt secondary to hypotension or another reversible etiology like a tension pneumothorax, right? You're trying to rule out other causes for it is where they're going with this. The patient has a tension pneumo and they happen to have third-degree burns and you're like, wait a minute, do I need to do an escharotomy? Wait, the patient actually has a tension pneumo and that's why they're hypotensive. That's what they're referring to here. So high pressure with BVM ventilation despite removal of other potential obstructive hindrances. So they have a pneumothorax, the ET tube is somehow obstructed. It's actually in the right main stem because you basically intubate it all the way down like we've seen, I think one time earlier in one of the episodes, you can tell that ET tube was right main stemmed. High peak pressure and plateau pressures with low tidal volumes on a ventilator, persistently elevated end tidal CO2 despite adequate respiratory rate and tidal volumes. And letter G, blood gas with evidence of significant respiratory acidosis despite adequate respiratory rate and tidal volume. So overall, the patient in the PITT had multiple indicators for this procedure. We literally just went through A through G, and you could probably start picking that apart and be like, all right, it was this one and this one and this one, right? There's a lot of indicators for that, but I just wanted to bring up the University of Cincinnati indications for the procedure. I thought it was very well thought out, it was very well organized, so I'm gonna put that on the screen for you. So let's talk about the procedure briefly itself. For an escharotomy, you're going to either use a scalpel, typically it's a 10 blade, or electrocautery set to cut. Incisions are made through the entire thickness of the circumferential eschar until subcutaneous fat is observed. Avoid cutting through the fascia. When talking about the chest only, right, there's obviously a multitude of locations. I just want to talk about the chest specifically. On the anterior chest, the escharotomy should be made along the lateral aspects of the trunk. And so you'll notice them doing that here, with additional incisions placed across the upper trunk and lower trunk so that they really form this rectangle. So when correctly made, that eschar will expand open and the subcutaneous fat will be seen. You literally will see it open. So the PITT did an awesome job here. If the subcutaneous fat is not observed, that escharotomy should be made deeper. Any bleeding encountered after the escharotomy has been performed is venous, and that's going to stop with the application of thrombin-soaked pads, for example. So here in this patient, you're going to notice, the vitals on the screen, they were 83% on a ventilator, so obviously that's not good, right? They're hypoxic. It's not from anything else. We just talked about one of the criteria. They're tachycardic at 145. Clearly they're in shock. Blood pressure is 93/75. MAP is 81, but they're still in shock when you start calculating some of this out. Peak pressures are high. We've already talked about that. There's so much swelling. The chest is so constricted that we start to see this decompensation that they're demonstrating here and the need for that escharotomy.
Start at lateral clavicle. In. Down. Anterior axillary.
and lower rib margin.
The tissue's really popping out.
Which illustrates what?
The pressure underneath.
Your turn.
Here goes.
A little more pressure.
Yeah.
You make a decisive incision and get through the S curve into sub Q. Go back a little deeper on that first section.
Okay.
Yep, good. Looking good. Okay, now the horizontal incision, Dr. Langdon.
And connecting the two incisions.
That ought to do it.
Peak pressure's already down to the 30s.
And tidal volume is coming up.
SAT's 91.
That was wild.
Let's stress these wounds and send off the blood gas.
Well done. And very well taught, Dr. Langdon.
Thank you. About the whole thing with Santos and the seizure patient,
What about it?
I'm sorry for laying into her so hard.
Why do I feel there's a butt coming?
But I don't think she's a team player.
How so?
She's cherry picking cases. She gave Whitaker a shitty nickname after his patient died this morning. She's even harassing Giovanni to get a rep from her mom for surgery.
If she wants to be in surgery, what's she doing in the ER?
That's a great question. Why don't you ask her new BFF Garcia? I know that you've seen those two. I'm the only one calling her out, so she has an axe to grind. You've always said that being in the pit is like playing a team sport. A team has to be able to trust each other. If we have one weak link, this whole place goes to shit.
Good meeting.
So I've said this before, I did agree with what he told Santos, just not how he said it and where he said it. Again, a lot of things are going to have to change to make Santos either believable in season 2 as a second-year resident, rather she is, in the emergency room or she's, general surgery. Something needs to change to make this believable, because being 3 months in, she's a horrible intern. This is one of those, you have her as an intern and you're like, oh man, we're going to have trouble over the next 4 years. So some drastic things are going to have to happen to make this believable.
Ooh, Robbie, Dana's CT results are back.
No intracranial hemorrhage, no skull fracture, non-displaced nasal fracture.
Mind if I give her the good news?
No, go for it. And anything else she needs.
I got it.
Call Zazie and Family Med. They open up their urgent care at 5. Let them know we're sending up to 2 hockey kids.
Yep, Zazie and Fam Med. Okay, copy that.
And please check in on Earl. Poor thing got caught in the crosshairs of that mob fight. Maybe bring him another sandwich.
Yeah, okay.
No egg salad.
Dana, I got you. Okay, rest up, bud.
Oh, can take the girl out of the ER, but you can't take the ER out of the girl.
Old Dabs die hard.
Let me take a look. Whoa, she's a real beauty, all right. But your CT came back clean. Nothing Mother Nature can't heal on her own.
Too bad. Looking for a free nose job.
Probably get hazard pay.
2 for 1.
Ooh,
So this is why charge nurses are awesome. They literally run everything. Even with an injury after an assault, right? They are still grinding it out. To all my charge nurse friends out there and all my, charge nurses anywhere, much respect as always.
What do you call a group of brains who form a singing group?
What?
A Glee Club.
Oh, good one.
Keep me posted if there are any changes.
What's with Dr. Mehta and the jokes? You know why they say laughter is the best medicine? Because it's true. Laughter releases endorphins. Endorphins help relieve pain.
So what?
Dr. Mehta thinks that if a joke helps raise spirits and makes people feel better, then he's all for it. It's his special sauce.
Do you have a special sauce?
I'm pretty data-driven, but I really like to talk to my patients about their lives.
Data-driven, yet as a third-year EM resident, she agreed with slamming 3% on a seizure patient that was overall, it was incorrect, it was inappropriate, not standard of care, and could have resulted in killing that patient. Yeah, okay, I believe that you are data-driven. Again, this is a third-year EM resident.
Makes them feel important. She's waking up.
How are you feeling?
Are you trying to say okay?
Yes, the thrombolytics are working. Can you lift your right leg for me? That's okay. Try moving it from side to side.
Can you tell us your name?
Yeah. Oh, maybe you can type it out on the screen. Here. Vera? Okay, what's your last name?
Malahi?
Well, hello, Vera Malahi.
Oh man, seriously, I've said this in part 1. Strokes do not improve this fast after TNK or TPA. It doesn't even matter which one, they're not going to improve this fast unless the patient had a TIA and you pushed it and you didn't need to. Like, this is such a joke, 100% not realistic. While she is obviously not back to baseline, which if she would have 100% went back to baseline, I would have critiqued this even more. Patients with large vessel strokes like this do not improve within 15 to 25 minutes or however long it's been. Maybe it's even been shorter than that. I don't know. But overall, they would not have improved like this. Brian, one of my favorite ER pharmacists, Liz, same with you as well. This next part's for you. Brian, obviously we just talked yesterday about angioedema. I told you I was going to put this in there, and so that part is dedicated just for you. For those watching, we are going to take a deep dive here in a little bit, talking about angioedema. We're going to talk about that scene specifically, just because I think it's a very key thing, and I think a lot of it may be overlooked when you watch this, like, oh yeah, allergic reaction or angioedema, this happened because of this medication. We're going to take a deep dive. So for those that don't want to see that much medical stuff to really on that level, feel free to fast forward a little bit, but we're going to talk about that here in a minute.
Piece of work. Appreciate you dealing with him.
It was actually kind of fun.
I did not have that on my bingo card.
Well, patients under propofol are always a good time.
Yeah? What did you say?
Nothing to worry about unless you're concerned he still has a thing for you.
Oh, please euthanize me if I ever even consider it. But if I could go back, I wouldn't change a thing. Without Chad, I wouldn't have Harrison.
You're very lucky.
Right? Thanks again.
I was getting ready to take her up when she developed angioedema and her stats dropped.
All right, so visually it looks very realistic in terms of the angioedema. However, there are a few technicalities with this that many physicians that are reviewing this case may not pick up on. All right, so first let's talk about angioedema briefly. This reference is coming from an article entitled Angioedema Secondary to Tenecteplase, TNK, Use in a Patient with an Acute Ischemic Stroke, a case report. This is by Doctors Newman, Paremba, and Wilkerson of the University of Maryland Department of Emergency Medicine in the Department of Pharmacy. In quotes, angioedema is a swelling of the subcutaneous or submucosal layers of the skin or gastrointestinal tract, is a potential complication to thrombolytic therapy in the treatment of an acute ischemic stroke. And so keep this next part in mind. In these cases, angioedema develops due to increased levels of bradykinin, keep that in mind, bradykinin, as a result of the activation of the fibrinolytic pathway and the contact activation system. Angioedema can involve the tongue, the larynx, the vocal cords, leading to an occluded airway and death due to essentially asphyxiate. The airway's gone. It's vital for the emergency physician to know that this complication can occur to ensure appropriate monitoring for the development of angioedema. All right, so again, we're taking this step by step. We just, defined angioedema. We specifically mentioned what you can see. We talked about it in the setting of, agents like TNK, for example, and we mentioned the word bradykinin. So before I talk about the case in the video, we need to talk about really two things here: histamine-mediated reactions and bradykinin-mediated reactions. Numerous mechanisms can result in the development of angioedema, and these are usually classified based on the underlying substance causing the swelling. So histaminergic angioedema is due to the release of histamine. We see that in cases of allergy and anaphylaxis as well as other immunologic processes. So an example would be like a peanut allergy, for example. That's histamine mediated. When we treat that, right, we're doing steroids, we're doing Pepcid, we're doing Benadryl, we're doing Epi. We're targeting the histamine receptors. That's what we're doing. It's a histaminergic pathway, all right? Keep that in mind. Bradykinin-mediated angioedema, that's a completely different pathway, all right? I'm going to stress this so many times. For example, hereditary angioedema, you're going to see HAE in the literature. Hereditary angioedema, which is usually caused by a deficient quantity or function of the C1 esterase inhibitor. You're going to see medication-associated increases in bradykinin, including like ACE inhibitors, so angiotensin-converting enzyme inhibitors, medication. You're going to have angioedema from an ACE inhibitor, all right? In ACE inhibitor-induced angioedema, that ACE enzyme, which also acts as the primary enzyme to break down bradykinin, is inhibited. That leads to increased levels of bradykinin. So keep this in mind because there's two pathways I want you to keep in mind because we're going to talk about treatment, all right? So I mentioned a few examples with the one, I mentioned a few examples with the other, so kind of keep that in mind. All right, so if you're following me so far, we've been taking a step-by-step within this angioedema, defining it, what to see, in addition, two different pathways, all right? So keep that in mind so far. The largest published trial comparing alteplase versus TNK, basically what they looked at was angioedema, all right? For example, in TNK and TPA, they just looked at what was the overall percentage of patients that developed angioedema in both, all right? So 9 patients out of 800 patients, that's 1.1%, experienced angioedema. I just wanted to mention that with how rare it is. So already you're looking at basically 1% of patients that get TNK are going to have angioedema. So keep that in mind. Again, in ER, emergency medicine, common things are common, but you still have to consider them. So it made sense that the PITT was going to do an angioedema, but you can already see 1% of cases, and we just happen to have, that case here on the PITT. In another study performed by Rose et al. Performed a systematic review and meta-analysis of complications of TNK and TPA for stroke and found a cumulative angioedema rate of 0.56% in patients with TNK compared to 0.63% in patients receiving TPA. Overall, we just say a 1%. Again, multiple different studies looked at this. Overall, it's rare, but 1% basically. So at this point, you have a patient that rapidly improved with TNK. Overall, that's fake. Then you have a patient experience a rare event like angioedema with roughly 1% of patients experience angioedema, right? That's where we're at. So let's dive deeper. The article goes on to state specific characteristics of patients who experience angioedema are seldom reported in the medical literature. A 2022 meta-analysis from Mas-Serrano et al. Found prior treatment with ACE inhibitors. This is key here. This particular meta-analysis looked at, of all the patients that had angioedema from TNK, what were their risk factors? All right, that's even key. So we're taking a step even further. Okay, what if the patient had an allergic reaction or angioedema from TNK? Did they have risk factors for it? We're already talking about something that's rare. So that's where the study is picking up. And they found that prior treatment with an ACE inhibitor, patients were diabetic, they had high cholesterol, female gender, and hypertension were associated with the development of angioedema after TNK, which means all of those things kind of increase their risk for TNK. So in that 1% of patients, these were their risks. So you can imagine if you take all of those risks away, or nearly all of them, that percentage goes down even further. There is actually the only published case report of angioedema. I had to do a deep dive on this one. The only published case report of angioedema after TNK administration actually occurred in patients who were using an ACE inhibitor, which is a known risk factor for the development of angioedema. So was this patient on an ACE inhibitor, right? Was the patient in question on ACE inhibitor? I don't think they mentioned any of that or any of that particular medical history, so that we don't know. But again, I wanted to kind of put that caveat in there. All right, so you may be saying, okay, Dr. Taylor, let's say she has all the risk factors. She's on an ACE inhibitor, female gender, maybe a history of hypertension. Let's give her every risk factor. That's how she ended up with, angioedema from TNK. She was that 1% because of these risk factors. Let's just put that in there. You may be saying, well, how do I treat it? Well, that's interesting because there's currently no studies to determine the best treatment of angioedema following TNK administration. Overall, the primary goal is to ensure airway patency. So despite histamine not being the substrate causing the angioedema following TNK, some have suggested that it still should be treated similarly to allergic reactions by administering antihistamines, steroids, epinephrine. 100% true, we do this every time. That is why multiple protocols are going to do this. Just realize epinephrine doesn't do anything to improve a reaction on the bradykinin-mediated pathway. Not even the same pathway at all, right? It's a bradykinin-mediated pathway. This is not a histamine-mediated pathway. The type of angioedema related to TNK follows the bradykinin-mediated pathway, meaning essentially supportive care, airway protection, and the potential for a few medications. Now, do we still give Pepcid, Benadryl, steroids, Epi? Do we do all these things even though they're histamine-mediated? Absolutely, yes, every single time. For that rare chance of anything being histamine mediated. If we have, for example, an angioedema that comes in and they're on an ACE inhibitor, but they also think they got bit by something, right? Is this an allergic reaction because of the ACE inhibitor? Are they having like angioedema because of the ACE inhibitor and it's bradykinin mediated, or are they having it and this is histamine mediated? That's why every single one of these cases, we're going to still give typically 40 of Pepcid, 125 of Solumedrol, 50 of Benadryl, and then we're giving epinephrine. We're doing that every single time. We're giving 0.3 to 0.5 milligrams IM Epi. We're doing that every time. So will these meds reverse the bradykinin mediated pathway? The answer is no. All right, now we have the potential, there's multiple studies out there. When it comes time for an ACE inhibitor, someone comes in, the tongue is sticking out, you're gonna lose that airway. Yes, when it comes to airway, you're doing everything you possibly can. We're gonna give all the histamine meds. In addition, you can consider TXA, FFP, C1 esterase, concentrate. There are a few things that you can consider, and there's multiple studies that look pros and cons of both and things like that. When it comes to the airway, though, that airway needs protected. And so in this scene, what they gave was appropriate because they gave Epi, and then she gave that first, actually, and then they mentioned the other meds. That's totally fine. Now, was I buying the rapid improvement with IV Epi? There you go. If you follow me along, you may be realizing, wait a minute, we're a bradykinin-mediated pathway. Dr. Taylor, you just mentioned the meds for histamine. We give them anyway. So it doesn't make sense if we're saying this is angioedema from TNK, bradykinin-mediated, I give you Epi, and you immediately improve like that. Makes zero sense, absolutely no sense. So that part I wasn't buying just based on the pathway, which, and the other part of this is she gave IV Epi, and we're not doing that for starters. Typically we're gonna give IM Epi, it's literally ready to go, and the resident would not have pushed it. So overall, I don't buy that particular part of the scene. They would have just been better not including an allergic reaction, to be honest with you, or if they did, show us the bradykinin mediated, right? This is the patient, they're getting set to intubate, they're getting IM Epi, steroids, Pepcid, Benadryl, they're still getting worse. Ultimately, they intubate the patient, right? Show us what actually happens. Overall, though, per the University of Maryland article, individual cases are rarely reported in the medical literature. We just happened to see one of them on this TV show. So overall, that was a lot. I know it was a lot. We spent a lot of time on it. I tried to make it as basic as I could. Again, from a surface level, you watch this, you're like, oh, it's great. Angioedema, they got meds, they got better. But we just took a deep dive so far down that I hope you realize how unrealistic this part of the scene was. When you specifically talk about the pathways of bradykinin versus histamine mediated.
A little bit of stridor, swollen lips, swollen tongue. Here, this is a side effect of the medication we gave you.
Sats are up with high flow nasal.
It's anaphylaxis, get Robbie.
Angioedema is not always anaphylaxis.
So a lot of things happening here. Dr. Mohan mentions this is angioedema, and Dr. King states this is anaphylaxis. Now, after having just mentioned everything related to angioedema, you're probably like, well, clearly, Dr. Taylor, this is not anaphylaxis, and you'd be right. But let's talk about anaphylaxis briefly. Anaphylaxis is a systemic reaction. Typical features include a feeling of doom, hypotension, often with loss of consciousness, diarrhea, vomiting, and abdominal cramps, laryngeal edema, and bronchospasm. So urticaria, those hives may be present, but up to 50% of reactions may not be accompanied by the rash. So the difference between angioedema versus anaphylaxis. Remember, angioedema is a localized swelling in deeper layers of the skin or mucous membranes, whereas anaphylaxis is a severe systemic allergic reaction that affects the entire body, potentially leading to life-threatening symptoms like difficulty breathing, a drop in blood pressure, and shock. This is what epinephrine treats, right? This is histamine-mediated pathway. This is what all your meds are going to be treating. Anaphylaxis from a bee sting, anaphylaxis from, a peanut. That's what we're treating here.
I know, but it can progress to it and cause an obstruction.
If it's just angioedema, I can reverse the swelling fast with IV epi.
BP is 165 over 85.
Prep ketamine and rock for intubation.
Whoa, wait. Dr. Mohan, you just said...
We're not intubating yet.
But she's gonna arrest.
What happened?
Angioedema with stridor. Respiratory's on their way. We should intubate, right?
I mentioned this on a previous review with residents arguing back and forth. Remember, this case is only one resident's case, and there shouldn't be any arguing back and forth. Overall, this is kind of ridiculous. Is this anaphylaxis? Is this angioedema? Again, now you should start looking at your stats for anaphylaxis secondary to TNK, or your stats from angioedema, or is there anaphylaxis from TNK, or is this angioedema from TNK? So let's take a look at the annals of emergency medicine for this one. Anaphylaxis is highly likely when one of the following three sets of criteria is fulfilled. I'm going to put all of them on the screen for you, but we're just going to go through one of those. Acute onset of an illness with involvement of the skin, mucosal tissue, or both. So generalized hives, itching or flushing, swollen lips, tongue and uvula, and at least one of the following. So respiratory compromise, so your shortness of breath, your wheezing, bronchospasm, stridor, reduced peak and expiratory flow, hypoxia, and then letter B, reduced blood pressure or associated symptoms of end organ dysfunction. So already in this case, we did have the mucosal tissue involved, and we had the shortness of breath. So I can see why one of them would say allergic reaction, and versus the other one say, this is angioedema. I can see why they would say that. While a reaction to TNK like this is already rare enough, it is the angioedema, though, that we can actually see, so not so much the anaphylaxis. But you can see why we talked about earlier that you give both, right? Even though angioedema from TNK, 1%, that's what you're going to typically see. It's bradykinin mediated. We still give all of these meds for the rare chance that you're dealing with that histamine-mediated reaction. So again, there's other criteria on screen. I'm not going to mention all those for the sake of time, but feel free to pause and to take a look. Overall, this was a kind of a deep dive into angioedema versus anaphylaxis, just with some of the subtle things that they talked about.
With BP and O2 sats, epinephrine can reverse the swelling right away. I pushed 10 mics of IV epi, starting her drip at 5 cc's, 5 mics per minute.
Sats are holding at 95 on high flow. BP is good.
Dear, we're gonna sedate you so that we can help you breathe better.
Or not. Let's just wait a minute.
How'd you get that epi drip on so fast?
Bedside drip. I mix 1 milligram with a liter.
Nice.
Are we intubating? Are we not intubating?
Not.
Stridor is improving.
Is it getting easier to breathe?
Speech is coming back. 50 diphenhydramine, 125 solumedrol.
Do you think Dr. Mehta will want her intubated for the thrombectomy?
Not necessarily. If she can talk and move during the procedure, then they can monitor any changes in the neural exam. Slow-mo, no-mo. Sorry, I think Dr. Mehta's rubbing off on me.
The dynamics overall of this scene were a little bit chaotic. Also, I keep harping on this. When will the resident stop pushing medications the nurses push? Communication is everything. Nowhere in this entire case did Dr. Mohan state she was making a push dose medication or a dirty epi drip. The nurses had no idea what she was doing. She just did it. If I see this patient in the ER, vitals are essentially stable, We have stridor, tongue swelling. What we normally do is we're going to give 0.3 to 0.5 milligrams IM-EPI. We're given 125 milligrams of Solumedrol, typically 50 of Benadryl, 40 of Pepsid. We have everything set to go if needed for intubation, depending on where we're at in the patient's history. You could talk about FFP and all these other things, but again, those are kind of a side note there. But we're doing all these things. We want to make sure everything is set up and ready to go in case we have to take that airway.
We're taking him up to our burn unit. He'll be in great hands. They've had lots of experience with cases like Teddy's.
What now?
We will continue with IV fluids and pain meds. We'll support his breathing with the ventilator, and we'll keep his wounds clean, look for any signs of infection.
Then later, the plastic surgeons can do skin grafts.
He's gonna be okay.
Teddy's condition is very critical, so no promises, but our team's going to do everything they can to give him the best chance possible.
I'll make sure to stop by the ICU, check in on both of you.
I can't begin to thank you enough, Dr. Whitaker.
Oh, student doctor.
Oh, don't forget about dinner at the farm. And make sure to brush up on your diaper changing skills.
With 7 nieces and nephews, I'm a diaper genie, so...
You know, you just called yourself a trash can, right? Before you grab your next patient, call Kiara, have somebody go upstairs and talk to the wife.
Amy, why?
We wanted to give her hope, but the reality is her husband's not going to make it.
He's stable.
His chance of dying in the next week is over 90%.
So chance of dying in the next week is over 90%. At first, that sounds like a brutal thing to say, right? No compassion. That's what it sounds like. But then you realize, no, he's stating stats on that one. The patient is going to the burn unit. They're going to be assessed by burn specialists and plastic surgeons that over the next few days and weeks can give some more accurate stats. So I do not believe this is a conversation that Whitaker needs to be having with her at this time. Even if they did form a relationship, this will not be taken, this case is going to be taken over by the burn team. Wouldn't you rather have the burn physician assess you, continue the treatment, and then give you a prognosis? So in this case, Dr. Langdon, he states the mortality. Yeah, that's okay. But telling the wife that before the patient is assessed by the burn physicians, like, why would you do that? Like, that makes no sense. Like, multiple different studies, younger patients versus older patients, risk factors versus no risk factors, appropriate fluid resuscitation, management at a burn center, escharotomy, skin grafts, reducing the risk of infection. All of this is going to have an effect on mortality. You're also going to notice here so much management of this burn patient, and nobody had mask on, which is just inappropriate in this case, as that is standard of care when you're managing a burn patient to have mask on. Side note, overall, all the studies I looked at had various numbers, some 65%, some 85%, some 90%, some approaching 100%. The point is, it's a high mortality rate, but it's also based on what we talked about. It's not just that you have this burn and this is your mortality. So much more goes into that. The burn team is going to take over. The burn team is going to assess that patient. They're the ones that are going to form that next relationship and can break that particular info. So I disagree with what Dr. Langdon was saying here. I 100% disagree with that.
He's young, he's strong. Maybe he's the 10%.
Maybe, but he's a lot more likely to die of sepsis before his kid is born. Call Kiara.
Die of sepsis, yet nobody had mask on in this situation. That's interesting. Die of sepsis. And Dr. Langdon, you didn't even have a mask on. So for this, let's actually turn to Vanderbilt University Medical Center burn protocol, in quotes. For burn patients, any patient with greater than or equal to 20% total body surface area, wow, our patient had way more than that, of open wounds will be placed on isolation. Any person actively participating in the wound care of a patient, of a burn patient, will wear a gown, gloves, mask, and hair cover for the entirety of the wound care. I'm pretty sure nobody had all of that on, if I recall. Nobody actually did that. So infection risk just went up. Mortality risk just went up. Great job, guys.
The CT shows a hairline orbital floor fracture. But thanks to the canthotomy, the hematoma isn't pushing on his eyeball.
Will I be able to see?
That's why you need surgery. The ophthalmologist will drain the blood inside the front of your eye and replace it with the clear fluid you need to see. Okay? We're ready for you now.
Hey. Don't worry, bud. All right?
There's a waiting room up by surgery, 6th floor. Right off the elevator, you can't miss it.
Angioedema responded to epi, diphenhydramine, and steroids.
Excellent.
Thank you. You're very welcome.
Which neurotransmitter makes the best adhesive?
I don't know.
Glutamate. Glutamate. Am I right?
Nicely done, Dr. King.
Dr. Santos, a moment, please. So, how's your first day going?
So far, so good.
Getting along with everyone?
Yeah, pretty much.
Except Langdon? So, in this ER, we all need to work together as a single unified entity. And if two people on my team can't work together, it kind of throws the rhythm of the place off.
Understood.
My duty, regardless of personal relationships, is to make sure everybody on my team is doing okay. So, are you doing okay?
It's not a big deal. I can handle it.
Handle what?
Nothing. It's fine. I don't want to get anyone in trouble.
Okay, if there's anything that could affect my ER, I need to know about it, and you have a responsibility to tell me.
The benzos finally come into play here.
Did they catch the bastard who sucker punched you? I haven't heard. Well, when they do, just send them to me. I can make it look like an accident. Let me just take you up on that. You betcha. You've been paroled. Are you sure?
Yep.
Oh, okay. Yeah, okay.
Yep.
Go check on Myrna.
Got a sec?
Bless you.
For you, boss, I got two. What's up?
I heard there's been some inconsistencies with meds intended for your patients.
What?
Frank, have you been helping yourself to benzos from the ER?
Yeah, I've been stealing blood, too.
I asked you a question.
Wait, are you serious? What are you doing? Really? Santos? Whatever the hell she told you is bullshit.
I didn't mention Santos.
You didn't have to. I told you, she is trouble.
Have you ever taken a patient's medication?
This is insane. This is completely fucking
I
insane.
need you to open your locker.
Yeah, right.
Open your locker.
You're gonna regret.
Open your fucking locker, or I will have security smash it open. Is the imprint code on these pills gonna match Louis' Librium?
So you can tell Dr. Robbie does not want to believe it, but he has to ask the questions. He needs to find out what Dr. Langdon should have done before, stealing patient meds, before ever getting to that point, before getting himself in that situation, is that when he realized there was a problem, let his program director know, right? You're having this problem, go talk to your program director before it advances to that point. Start treatment, start rehab, and then come back versus trying to do it on your own by stealing patient meds to slowly wean yourself off your own meds. So it's disappointing for sure in what is a promising future attending. Obviously, we know where this goes. He comes back for all the traumas that we're going to see again. I can't wait to critique episode 12 through 15. But obviously, he's going to come back. We'll talk about that a little bit later. But overall, disappointing, but realistic in that I'm sure it does happen. But I don't have any particular experience with that part of it, so I can't critique too hard on that because I'm sure this does happen, but I don't know how it's going to happen or how that's managed from that standpoint when you have the medical director, but then also the program director and assistant program director don't know. So it's kind of a weird dynamic there. So again, I can't critique it because I don't have any experience with that. Again, if you're if you're an attendant and you do have experience and you want to share one of those stories or one of your experience that you had, feel free to put that in the comments. But again, I don't want to critique something that I don't specifically have experience with. I was going to reach out to one of the program directors, a few of the program directors I know, and see if they had any cases over the years of something like that, but I didn't have time to do it for this particular critique of how busy I am. But overall, again, we obviously know Dr. Langdon is going to come back, and hopefully in season 2, he's going to be pretty awesome.
Go home, Frank. No, it's not like you think. You remember whenever I helped my parents move, I was too cheap to pay for movers. I hurt my back. I told you that. You teased me about it. Remember? Well, our own Dr. Hagen prescribed me some pain meds and muscle relaxers. I was just weaning myself off. It was just for maintenance. I'm done. Robbie, come on. You know me, Robbie. You know me, man. I'm sorry. I fucked up. I was trying to...
What, steal pills?
No, it's not like you don't understand.
I don't fucking understand.
It's not like you think. I'm not high. You've seen what I do, Robbie. Could a drug addict do what I do?
Apparently. I just fucking let him. You're done. Leave now, or I will have Ahmad escort you out.
Robbie, please.
You are done. What?
Well, that concludes the episode 10 part 2 critique. I hope you loved it. I've said this numerous times. This is the most realistic, and while not 100% accurate, it's the most realistic and most accurate medical drama of all time. I highly recommend the PITT. For those watching, all I ask is that you subscribe to the channel, tell your friends, share the channel. I have a night shift tonight, so I'm going to call it good for now. Next up, episode 11.